can start. Any question to the speaker panel, please?
My question, when you have two moderate risk factors, or one, in the context of a young patient or a patient with family history of keratoconus, does that give more weight to your one moderate risk factor? You change your mind about doing surgery?
Thank you very much for this question. So your question is, when I have only one moderate risk factor in a young patient with a family history?
Or a family history.
Or a family history.
Yes. I think very important not to be a technician in any ophthalmology setting, because we are still treating patients. Family history and patient age is very important risk factor.
Yes.
In refractive surgery.
Yes.
So in that context, when you have just one moderate risk factor,
Mm-hmm.
do you make it more important when you have family history or other clinical facts?
Understood. Thank you. I will answer. Actually, the risk factors that I have presented are in terms of topography and tomography only. Of course, there are many risk factors also, like the PTA ratio that should be calculated in every patient. When I have PTA above, which is the percent tissue altered, above 40%, so I cannot go for LASIK. Age of the patient, family history, constant rubbing of the eye, many other factors. Now, when I see a patient, even with very normal cornea, but one of his brothers or sisters have keratoconus, I will not touch the cornea, even if it is very normal. And this is one of the definitions of form frost keratoconus. Form frost keratoconus has two definitions. The first one is abnormality in the eye, which is not sufficient to classify this eye as keratoconus. And the other definition is very normal eye in a member that has brothers or sisters having keratoconus. So in such case, even if it is very normal, no moderate, no high risk factors, I will not touch the cornea. This is one thing. The other thing is, if the patient is young, let's say between 20 and 30, and keen for refractive surgery, he has only one moderate risk factor, nothing else, I can go for surface ablation. That's it.
Any other question, please?
Actually, I have to close mine first.
I totally agree that there are other risk factors different than those derived from the anterior surface that you showed very well and very didactic way. The age, the gender, the family history. But we have to be sure that the posterior surface is good or not. The posterior surface is one of the best indicators for initial deformation of the cornea. And you have to see curvature maps, and you have to see both best fit sphere and best fit toric spheric maps from the posterior surface and have good numbers. If you are not able to set this, I would not go for surgery, because I believe that something else can be in that cornea.
Thank you very much for your comment, and I agree, of course, with you. Now, the comment you have mentioned before you started regarding best fit toric ellipsoid and best fit sphere, which is better for studying. Actually, this is still debatable, and this debate is between Theo Zeiler and Jack Holliday. One is using the best fit sphere, and the other one is using the best fit toric ellipsoid, and I think both are right. So this is why I put we have to study both, because from, in my opinion, if I want to see, if I want to highlight something, I have to put it among things that are different. Like if I want to highlight somebody who is wearing white, to see him very well, I have to put him among people dressing like black. But if I want to measure, the thing I'm looking at, I have to compare it with things are comparable. So if I want to measure the height of something, I cannot measure this height with things that are different. I cannot measure the, like a tree in comparison with, let's say, with a cat. I have to put trees all together, and then I can measure the one of interest. So the surface of the cornea is toric ellipsoid. So if I want to study the shape of the cornea, I have to use the sphere in order to highlight the problem. While if I want to do any measurement on the cornea about heights and depressions, I have to use the toric ellipsoid. This is my idea.
Okay, please. Go ahead.
Can you hear me? Okay. I love your comparisons or your metaphors. And we have also another one. When we use the best fit sphere, we are comparing our football ball against the American football ball. And the American football ball is imperfect because it's not a ball, it's an egg, okay? And it's not foot because they play with the hand. Our football is the real football. So the difference between these two shapes is the peak of the egg. So we are going to see the peak of the mountain comparing these two surfaces or these two shapes. In the best toric aspheric maps, we compare the American football ball against a rugby ball. So these are very close. So when they don't match each other, we are going to see the yellow zone when it's above and the blue zone when it's below. So what we are going to see is the asymmetry. It's like the mountain, which is perfectly symmetric, or if the mountain is tortoise, okay? So with this way, we can identify the two main factors that produce the diagnosis of keratoconus, which are ectasia and asymmetry. You presently may have ectasic corneas, but not asymmetric, and you may have asymmetric corneas, but not ectasic. Asymmetry below 47, okay, or very symmetric in 50s or 51 diopter corneas. So are these corneas keratoconus? No, for me are not anymore. These corneas may be stable for the whole life until you touch it. When you touch it, bingo. So these corneas for me are normal corneas with risk factors, okay?
I think the last question, please.
Thank you very much for this fruitful information. I'm Dr. Nasrallah from Maghrabi. I would like to ask about the contact wear page for Dr. Mazen. You said we use usually 1 week for every 1 year. Some patients, you give them this time and still there are the changes. So are they fit to label them as unfit for surgery, or we give more time waiting, or? Thank you very much.
Thank you very much. Yes, you are right. If I give sufficient time for the patient to take off his contact lenses and to be sure that she, between brackets, she has stopped them very well, not only, most of ladies come, I just used it for a couple of hours, maybe 2 days or 3 days before because of an occasion, and we have to be sure that it has been stopped completely for the sufficient time, and then if still I have these irregularities, then I will classify as moderate, high. So, no need to wait for maybe a couple of months. The longest period that you have to wait is 1 week per 1 year of usage.
Thank you very much for coming. We conclude and we can go now for the break, please. Thank you very much.